It's a pleasure to be with you today. My name is Jillian Woolard, and I am a board certified behavior analyst. I've been working at the Storck Center for about 3.5 years, mostly with our adults, but also doing some consulting and work with children and toddlers as well. So I'd really like to tell you about the basics this morning of how behavior analysts view, evaluate, and treat problem behavior, really with the goal of letting parents know how we operate, how they can start to think like a behavior analyst, and also all of the work that they can do as parents and as families to help their children, even if their child is not yet in ABA therapy or is only experiencing minor behavior problems, in order to avoid them becoming more major behavior problems, or if your child is on a wait list and is not yet receiving services, so that they can start the work of establishing better behavioral patterns in their children. This is obviously a team effort. We would never want to put everything on the parents, but then equally, we would never say, oh, let's wait for therapy. Therapy is going to fix everything. It was really remarkable in Jen's wonderful presentation when she had the little equivalency there, that if a young child were only receiving speech therapy for 20 to 30 minutes twice a week, it would take them 84 years to get the sufficient number of exposures to various spoken material for them to actually make progress. So it's exactly the same in behavior services. It needs to be a team effort, wrap around the child wherever they go, whomever they're with. So I'm going to give you some of those basics so that whether or not your child is currently receiving behavioral services, you can start to think like a behavior analyst and evaluate and treat your own child in a way that is going to be effective and meaningful for them. Just like any science or therapy, there is an enormous amount of clinical terminology. I'm going to use some of it and try to explain it. And please let me know in the Q&A if there are any terms that I used that I did not clarify. These are terms, of course, we're throwing around all the time, and it can get pretty jargony. First of all, what is ABA? So ABA stands for Applied Behavioral Analysis, and it is the therapy that's based on the science of learning and behavior. So that's quite broad. The A part of applied means that it's the application of all of these scientific principles that have been discovered or developed in lab work or clinical work. Everything that behavior analysts do is based on peer-reviewed research. We're really not allowed to implement anything that hasn't been shown to actually be beneficial. So we would never treat a child in our therapy, let's just try out some random things that maybe have some backing and maybe don't. Everything that we do can be traced back to peer-reviewed research. This is really important, especially as the internet has exploded with so many resources, but maybe not all of them are actually warranted, or not all of them really are coming from the right place where people are trying to help children as opposed to just trying to make money. And there can be a lot of quackery and misleading parents to try something that might be expensive and promise amazing results, but actually really doesn't. So it's very important to reference back to the literature in empirically valid journals. Not that parents need to do that, but to make sure that those resources are there. Another thing I want to clarify about applied behavioral analysis is that it is not just a treatment for autism. It is often associated with autism because ABA therapy can be quite beneficial for many children and adults with autism. But ABA can be used across many populations, and even typically developing children and adults. There are clinical applications across the lifetime and across disabilities, and like I said, even neurotypical individuals. So those are just a few points I want to make about ABA before we begin. So what is behavior? When behavior analysts talk about behavior, what do we mean? We actually mean something quite clear and defined. Behavior could be defined in a lot of different ways, but when behavior analysts talk about behavior, we mean behavior that is observable or that is visible. We don't mean things that you're thinking or feeling within yourself. Obviously, those are incredibly important and valid, and if they need to be the focus of treatment, they can be, but typically it wouldn't be the focus of treatment for an early intervention ABA program. We're really looking at things that you can observe. If you can observe them, you can also measure them. Like I said in my introduction, behavior analysis is highly focused on data. So in order to take clear data on something, for instance, how often something is happening, how long a behavior is lasting, what time of day it's occurring, when does it stop, when does it start, all of those different measurable elements of behavior. If you can't see the behavior happening, then you really can't collect those types of data on that behavior. So for behavior analysis, we define behavior as being observable and measurable, and also that we can define it clearly enough that even a stranger would be able to recognize it. So if we're defining the behavior of hitting, for instance, where we need to say, is it an open hand? Is it a closed fist? Does it mean a light tap? Does it have to leave a bruise? Is it audible across the room? There are many, many different dimensions of behavior that could be defined. As a parent, when you're looking to identify what are my child's problem behaviors, we really want to look at those three things. Like, what would a stranger observe them doing? Is it dropping to the floor, screaming loud enough that they're heard across the grocery store? Is it kicking? Is it biting? A lot of those different behaviors, clearly defining them, and then finding out a way to measure them. So are we going to look at how long they're lasting, how many times they happen? And we'll talk more about how to collect data on your own child's behavior later on. It's very important to start thinking of those elements in pretty clinical terms, even though it's emotionally distressing, obviously, for the child, for the parents, for the whole family when problem behavior is happening. It's very important to be able to step back just a little bit and look at what's happening objectively in order to be able to take the next steps in figuring out what's happening, why is this happening, what can we do about it. So in ABA therapy, there are two main components of treatment, and parents can learn to be very skilled at implementing both. And there's not one that's more important than the other. They're both equally important. If we don't do both, we're not really going to see behavioral progress. Most of the time when a child is referred for behavior therapy, it's because they're engaging in problem behavior that parents would like to reduce. And so oftentimes we talk a lot about how do we get rid of this problem behavior? How do we get rid of biting, of whining, of running away, of ignoring me when I give instructions, of refusing to get dressed, of being a picky eater. There are so many problem behaviors that children might be referred for. We need to always remember, though, that every time we reduce a problem behavior, we must be increasing at least one other prosocial or appropriate behavior. So we can't just eliminate behaviors from a child's repertoire. We need to replace those problem behaviors with appropriate behaviors, age-appropriate behaviors that they can learn, that they can engage in to replace the problem ones. And we'll talk a lot more about that later. Oftentimes in your behavior plans, you'll see the target behaviors, so behaviors that are being targeted for reduction, and the replacement behaviors. So for each of those, what are we replacing those problem behaviors with? It's important to understand that in behavior analysis, we consider that all behaviors have a purpose, that they don't just happen randomly. Humans tend to be very efficient and very lazy. So people don't engage in behaviors again and again and again if they're not getting anything out of it. They're going to only continue to engage in any behavior, whether we consider it good, bad, problem, excellent, whatever, only if for themselves it's actually bringing them something. It could be bringing them something external, such as praise, money, all kinds of things that they might want, or it might just bring themselves a feeling of pride, of accomplishment. But we don't do things for no reason. So we really want to keep that in mind. A lot of times I do hear from parents or from staff that something is happening out of the blue or for no reason. And clinically, we wouldn't say that that's the case. We would say that we just don't know what that reason is yet. Hopefully we can find it out. I'd like to refer back to another part of Jen's wonderful presentation, the video of the child playing with the rhythm sticks with his therapist or teacher. There was a brief moment when the child began to whine just a tiny bit, and the therapist immediately redirected back to, let's communicate appropriately. And that was an absolutely perfect little snippet of the overlap between speech therapy and behavior therapy. The speech therapist obviously has her goals. Many of them are actually going to overlap with behavior therapy goals, because in behavior therapy or ABA, I'm going to use those two terms interchangeably, by the way. We want to reduce the whining and we want to increase the communication. So the target behavior was whining, the replacement behavior was appropriate communication. And just in those few seconds, we saw a perfect example of that embedded in a speech therapy session. So one other extremely important principle in ABA is the principle of reinforcement. And again, reinforcement could be defined a lot of different ways. When we're talking about it in the context of behavior analysis, we're talking about what are the consequences for a behavior that are going to cause that behavior to happen again and again in the future. So like I said, we don't do things for no reason. We do them again and again because they're being reinforced in some way. So a child might have a lot of things that they like, but they probably don't have an enormous amount of actual reinforcers. To be a reinforcer, the consequence or whatever you're getting after that behavior actually has to make that behavior happen again. So an example for me is that coffee is a reinforcer because I'm willing to change my behavior. I'm willing to spend money. I'm willing to actually do something in order to access coffee. So it's a reinforcer for me. I'm actually willing to do something to allocate my resources in order to get it. Tea is a preferred beverage. It's something I like. If someone serves it to me, then I'll certainly drink it and thank them for it. But it's not a reinforcer because I wouldn't buy it. I wouldn't make it for myself. And so I'm not willing to allocate resources. I'm not willing to use my behavioral energy in order to access it. So when you're thinking about things that your child likes, hopefully they like a lot of things, and that's wonderful. And of course, we want to continuously expose children to new items, new activities, and see, what do they like? There are probably a handful of things that every parent could identify as actual reinforcers. My child is willing to change their behavior in order to access this item. Those really do need to be identified before you start trying to actively change behavior. Without a powerful enough reinforcer, it's going to be difficult to really have meaningful behavior change. As parents, you guys are coming to the table with a built-in wonderful reinforcer that's already there. It's with you all the time. It's you, yourself, your praise, your attention, your hugs, your kisses, tickles, all of those things. Almost universally for all children, their parents' focused attention on them and engaging with them in a fun way is already a built-in reinforcer. So that's where parents have a huge advantage over therapists or staff who need to create that relationship. And of course, it's never going to be as strong as it would be with a parent. The first part of ABA therapy, when a child first comes to the therapist, is to do what we call pairing. And it's literally pairing the therapist with reinforcement. It's building that fun relationship with the child. Well, fortunately, parents already have that with their children. They have been with them since before birth, and so know their child and already knows what their child really likes. So it would only take a few minutes really for a parent to identify 5 to 10 reinforcers for their child. And just remember that a reinforcer, it can be a toy or a TV show or an iPad or a song. It could also be a snack, a favorite, something favorite to drink, a favorite location to go. Could be visiting grandma and grandpa. It could be a lot of different things. We want to make sure that we're not only thinking of, for instance, an edible or a snack to eat. Unfortunately, in the history of ABA in the past, M&Ms have been used historically, for to teach a lot of behaviors. And it's like, well, maybe that's not the healthiest thing to use only, candy and sweets as a reinforcer. There are many other reinforcers. Candy and sweets and special snacks do have their place at times for learning very specific tasks. But we want to make sure that we don't overuse them. So just remember that you are probably your child's biggest reinforcer, and how you use your attention. I'd like to reference back to Emery's wonderful presentation earlier this morning, talking about occupational therapy and sensory issues. Reinforcers can also be discovered by looking at what a child's sensory needs, sensory preferences are. So a child who really loves to swing, we could think of other motions, of other activities that could be provided for that child that mimic swinging. So if it's a very young child, a parent can, swing the child themselves up and down, bounce them up and down. A child who really likes to sit and spin, a parent can swing their child around. There are a lot of ways that we can mimic the sensory activities that the child already likes, in order to have that activity always available to them, even if we're not at the playground and the swing sets are not there. A last thing I'd like to say about reinforcers is that once you've identified them and you'd like to use one or several of them in order to change a child's behavior, so decrease problem behavior and increase appropriate behavior, you want to limit access to that reinforcer. So just like us, if I had 20 cups of coffee, that coffee, at least for that day, is no longer a reinforcer. I'm not willing to I'm not willing to drink it anymore. It's the same thing with various reinforcers for kids. If they have too much access to them, they might get bored of them, and or it might just not be something that they're interested in doing for the rest of that day. So we just want to limit them and make them what we call contingent upon not engaging in problem behavior, and on the flip side, actually engaging in appropriate behavior. So try to restrict them as you're able and save them for teaching opportunities. So let's move on to how do we actually treat the problem behavior? How do we reduce the problem behavior? Sometimes parents will ask me, what do I do about biting? What do I do about running away? What do I do about hitting? What do I do about grabbing toys from the siblings? All of those questions have to do with what we call topography, or what the behavior looks like. So biting looks like chomping your teeth down on another person's body, biting down, hurting them. That's what biting could be described as topographically. However, while those are important and we want to have a good topographical definition that actually explains what the child is doing, what's much more important, and the very next step, is to figure out why the child is engaging in that behavior. So yes, as soon as we know these are the different topographies of the problem behavior, what we're really going to put most of our effort in during the evaluation process, and that's whether you're in formal behavior therapy or as a family, as parents, you're trying to figure this out for yourselves, is why is the child engaging in this behavior? What are they getting out of it? Why does it keep happening? And that process is called finding the function of the behavior. The function just means the reason that the behavior continues to happen. So as we're trying to figure out function, the first thing that is very important to do for health and safety is to rule out medical reasons for problem behavior. So especially for a young child who doesn't have good communication skills, if they start any form of self-injury, so for instance, hitting their own ears or biting themselves, that really seems to come without any reason, we want to make sure that they're not experiencing pain, or they don't have an ear infection, impacted tooth. It could be a lot of different things, and those need to be ruled out by the pediatrician, the primary care physician. So if a child starts abruptly engaging in really any form of problem behavior, but especially self-injurious behavior, we want to make sure that they're not experiencing an illness or pain or something that really needs to be treated medically. It's important to know that sometimes behavior therapy, if you don't rule out the medical causes, behavior therapy can actually mask important medical symptoms and make it more difficult later on to treat medical problems. So if there is a behavioral issue, first rule out medical causes, and that should be done frequently as a child is in behavior therapy. A new behavior emerges, the first thing the BCBA is going to do is figure out with the parents and with the doctor, is there a medical reason for this behavior? We also want to figure out the child's sensory sensitivities and how they might influence behavior. And we just learned all about that in Emery's wonderful presentation. So definitely refer back to that. So often what's considered or what looks like potentially a behavior problem is actually an issue with sensory processing, and that really needs to be investigated. So after you've looked at medical factors, sensory factors, let's look at some actual functions that behavior therapists treat. The first one I'm going to talk about is called the access function. Access just means getting stuff. So engaging in a problem behavior in order to get something. So what might a child want to get? As we've already said, your attention as the parent, another adult's attention, peers' attention. It could be a toy, it could be an activity, it could be their favorite song, it could be finding a YouTube video, anything that that child might like to eat, look at, play with, attend to, anything that they might want to get, all comes under the umbrella of the access function. So on the flip side of that, there is the escape function. So the escape function simply means escaping, so getting away from, avoiding altogether, or delaying anything that the child doesn't want. So it could be getting dressed, it could be brushing teeth, it could be eating foods that they don't like, it could be holding your hand to walk in the parking lot, it could be really anything that they're asked to engage in that they don't want to do. Any problem behavior that they engage in order to get out of that situation, get away from that task, avoid what their parent or teacher is asking them to do, all comes under the umbrella of the escape function. You can probably tell already that oftentimes those two go together. So the child might be presented with a worksheet to work on. They want to escape that and get back to the iPad instead. So oftentimes those go hand in hand. So when we talk about the access and escape function on its own, we're typically talking about things that the child is trying to get from their environment. So reach out and get a person's attention, or turn on the computer, or run outside and play on the swings, things that are out in their environment. But it's important to understand that that escape and access functions also operate within the body. When they're operating within the body, we call that the sensory function. And it has other names as well. We call it the sensory function because it has to do with how that individual, that child, what they're seeing, feeling, possibly thinking, smelling, tasting, seeing, and we can't know that. Only that individual can know all those things about themselves. So a child who is sensory seeking, they're actually being motivated by an access function on their sensory system. So that's obviously a lot harder to evaluate since we can't be in another person's body and know what they're feeling, know what they're seeing, know what they're smelling. Oftentimes we will evaluate and really look at the access and escape function that operates on the outer environment. And if really there are no clear answers, we're going to do a deep dive into that child's the possible sensory functions of various behaviors. So if it doesn't look like a child is doing something to get attention, or to get an activity, or to get an object, or to escape a task or escape a situation, but they're still engaging in that problem behavior, then we're going to look very, very closely at the sensory function. So what might they be feeling, looking at, smelling, hearing that is causing that behavior to continue? So we know these various functions. How do we figure out what a particular behavior, what its function is? Why does it continue to happen? Here is when we need to be good observers and take some data. The data collection does not need to be very complicated. You can just take any piece of paper and draw 3 columns on it. On the first column, you have A at the top. The middle column has B at the top, and the last column has C at the top. The A column stands for antecedent. So in behavior analysis, ABC model is how we analyze behavior and how we figure out functions. One of the ways, at least. And these is one of the ways that's immediately applicable to parents and other caregivers in that child's life. Everyone in their life who is able to write can take what we call ABC data. So back to A. A stands for antecedent. Antecedent just simply means what happened before the problem behavior. So you see a child biting. Hopefully you saw exactly what happened before that. If you didn't, you're just going to have to write unknown in that column. But really you want to be as detailed as possible with as much information as possible. So for instance, if you are at the dinner table and all of a sudden your child reaches over and bites their own wrist, obviously you want to take care of their health and safety first and not immediately start jotting down behavior data. But you want to train yourself to remember, observe, and later on document everything that was happening directly prior and even throughout the behavior. So you're at the dinner table, what time it was, who else was there, what was the child eating, had they finished eating, and then the behavior was biting. Did they bite once or did they bite 5 times in a row? Did you have to release the bite yourself, or did the child release it on their own? There are quite a few safety tips and tricks that parents can learn that we're not going to go over. I don't feel that it's really this is the correct place to talk about that, but if you are interested in knowing strategies for directly intervening in self-injury and aggressive situations with your child, you can definitely reach out and I can give you those resources because they do exist. And if you're just watching your child bite themselves, obviously you'd like to know how what the safe way is to interrupt that behavior. Okay, so we talked about antecedent, what was happening before the behavior, noting the behavior. So how often it happened, how long did it last, whatever it might be. And then in your C column, that last column, C stands for consequence. So in everyday speech, we often talk about consequences as being something negative or bad, like there are going to be consequences for that action. In behavior analysis, the consequence is just very neutral. It's simply whatever happened directly after the behavior. So the consequences could be parent released the child's bite and said, no, don't do that. Or child released their own bite and parent gave them a hug. It could really be absolutely anything. As you're taking data on yourself and your family and your child, you want to make sure that you're not artificially doing something totally different than you regularly do, because it's going to be really difficult to figure out the function if you're not doing what you would normally do. Your child developed those behavior problems in their current environment, so it's their current environment that needs to be documented. So do what you would normally do and just be sure to note that. So as the child engages in problem behavior across settings, maybe at different times of the day with different caregivers, we're going to start to have quite a few examples of when and under what circumstances this problem behavior is happening. And all of those circumstances can be looked at to determine the function. When we look at that consequence column, we can start to see, okay, maybe this is happening in order to, for instance, the child who's biting themselves at the dinner table. Maybe that's their way of saying, I'm done being at the dinner table, I want to get down and play. And I know if I bite myself, a caregiver will turn to me, take me out of my high chair and put me on the floor. Maybe they don't have another way to communicate that I'm all done, I want to leave the table. It's important also to know that a child or anybody doesn't actually have to be able to internally understand their own motivation for doing something in order to do it. So usually, eventually, people do figure out, oh, if I do this, this will happen. Sometimes, however, though, they might engage in a problem behavior and a variety of consequences happen. And maybe they weren't thinking that any or all of them would happen. But as they do, that behavior continues. That's what we mean when we say that a consequence can create a function. So for instance, I have treated fecal smearing in toddlers and preschoolers quite frequently in the past, because it's a distressing and unhygienic behavior. And oftentimes it initially occurs just as a sensory behavior. The child notices, oh, there's this stuff coming out of my body. It's kind of like Play-Doh. I'm going to smear it all over the place and all over myself. Oh, and it smells kind of funny. And they're just exploring their body, exploring their environment. They're certainly not doing it for any nefarious reason. However, when the parent comes upon them and they're covered in feces and have smeared poop all over the crib, mom or dad might have a huge reaction and, it's like, oh no, what did you do? That's not nice. Oh, that's so gross. And that might be one of the biggest reaction that child has ever gotten to anything in their life. So they're like, wow, if I really want a lot of attention and then to take a bath and spend a lot of one-on-one time with mom and dad, all I have to do is smear this poop all over the place and it's convenient. It comes right out of my body and wow, it's gonna really give me a lot of attention. They're going to stop everything else that they're doing to focus on me, get me cleaned up. And even though at the same time there might be some scolding happening or some displeasure on the part of the parents, if that child really loves the attention, whether it's perceived as good or bad, fecal smearing can absolutely continue. So initially the child was doing it for sensory reasons, but now they've learned to do it because they know it's going to guarantee one-on-one attention from a parent and probably a bubble bath. All right. So again, I understand that it can be tedious or it can be difficult to collect ABC data, but it really is the starting point for figuring out the function. And it's absolutely necessary in order to know whether the interventions put in place are actually working, because we want to see that the child is doing less and less of the problem behavior in order to either access or escape things, and doing more and more of the replacement skills that we're going to teach them. Once we figured out the function or functions of various problem behaviors, we obviously want to develop interventions. And we're always going to develop interventions that are function-based. So if biting had the function of escaping a non-preferred activity, we want to teach the child a way to escape that same activity without having to bite themselves. Now, of course, there are many, many things that children need to do that maybe they don't like, and they can't just permanently escape them. However, in order to decrease the biting, we want to first focus on teaching the child a way to at least temporarily pause that non-preferred activity or that non-preferred task in order to allow the parents or the caregivers to regroup and represent that task or activity in a more preferred way, without the child needing to engage in the problem behavior. So let's go through our various functions that we identified and talk about some interventions that can be effective in replacing the problem behavior with appropriate behavior. So let's talk about the access function. So that's when the child is engaging in a problem behavior in order to get something. Well, it doesn't take a behavior analyst or a speech pathologist to tell you that what we want to replace the problem behavior with is communication. And communication really can start happening from birth. I'm sure you've all seen videos or seen books about infant sign. So even for a child who's very young, or who has very, very limited or no communication skills whatsoever, who doesn't attend to pictures, who doesn't attend to the human voice, who doesn't babble. Maybe they really have very, very limited ways other than crying or problem behavior in order to communicate. We can still start using sign with them. So we can sign as we speak. So when we're saying more, signing more, when we're saying all done, signing all done, and then taking their little hands and prompting them to do it as well, so that they start to learn the muscle memory and start to associate that sound of the word, so more or all done, with that movement of their body. If we figured out, for instance, that a child is biting themselves in order to be able to get down from the dinner table, when we see they finished eating, or as we see them approaching to bite themselves, quick grab their hands and help them sign all done, so that they can learn, I don't need to bite myself, I can sign all done and I can get down. That's just a very, very basic little replacement, but you'll find that for children with problem behavior, the earlier that we intervene, the easier it is to replace those behaviors. So we really want to start working on them. We can even work on them when it hasn't even progressed to something as potentially dangerous as biting. Just whining can be replaced with a sign. Even if the child is whining at the same time, their hands can still be prompted to sign whatever it is that they want. And fortunately, very young children don't have huge, extensive, complicated needs. The most basic 50 to 100 signs are more than sufficient to help them communicate their needs. And pairing those signs with the spoken word, and then also as we're able to pair it with pictures and with the written word, all of those different ways of communicating really strengthen the child's repertoire. So it's historically been a myth that if you sign with the child, then they're not going to try to speak, because it's like, oh, I'll just sign. That's absolutely not true. Research has proven and shown many, many times that signing and speaking at the same time really does encourage the use of vocal speech for children who do have that capacity. When behavior analysts talk about communication, we almost always put it in the context of what's called FCT, or functional communication training. And while there is a lot of overlap between speech therapy and behavior therapy, in behavior therapy, we really focus on this functional communication training. So like we said, function, the reason why a behavior problem is happening. In our communication training, we're really working on how can we as quickly and as easily and efficiently as possible replace that problem behavior with a form of communication, even if it's not grammatically correct, even if it's not perfectly signed. So a child who is not able to sign more like this, but is doing something like that, we're gonna be like, yes, you wanted more of the swing, of tickles, of baby shark, whatever it is, even though it's not perfectly signed. So just so that you know, oftentimes behavior therapists and speech therapists will be working on very similar things, but the speech pathologist has a lot more resources and expertise in getting some really great communication happening. Behavior therapists tend to focus a lot more on, let's make sure that that child has a way to communicate that replaces their problem behavior as quickly as possible, even if it doesn't look pretty and it's not perfectly formed or perfectly spoken. All right, so that's our first thing we really want to think about when we're working on the access function interventions. All right, so wanting to get something, that's great if we can ask for it. If we could get it immediately all the time, then wonderful. There's no, we can just sign for it, we can speak for it, we can point to a picture and say, I want that. If we could get it right away, then there's no reason to engage in problem behavior. However, the reality is that adults or children, none of us can have everything we want immediately all the time. So we need to really start teaching the child to tolerate delay in getting what they want. And we can do that in a variety of ways. The first way is simply to teach them the concept of first then. So first then is basically showing them that we're going to first do whatever we need to do, and then they can have what they want. So a child who communicates that they for instance, want to listen to Baby Shark or watch Baby Shark on YouTube. But at that moment, we are finishing up a puzzle, for instance. There are a lot of different ways to show that we're going to do this thing first and then do that thing. If you have no other visual materials around you, definitely want to learn the signs. So, first we're going to do such and such, and then. The more that you have used those in the past, as soon as you start signing first and then, the child will realize, okay, you're acknowledging what I want, and I have enough examples in the past of that actually happens. When I ask for something and you say first then, I don't need to freak out. I don't need to get really upset. I don't need to have a tantrum and drop on the floor. You've acknowledged that's going to happen, and it really is. So having that first then concept as early as possible is extremely important. Signing it is great. It's even better to actually have a visual of it. So here is, sorry, this is going to be reversed, I think, on the camera. One that might be used in a classroom. So it's just, Velcroed pictures. This is a basic first work, and I think that's like a magnetic sand bin or something like that. So we know this child really likes the magnetic sand, or maybe they've picked from a choice board. This is often used in classrooms and therapies, but it can be equally used in the home. You know what your child likes, have some pictures of it, have the variety of things that you'd need them to do, and put it on a first then. A first then can transform into a first next then, or something that's even longer, that has a whole sequence of, for instance, their entire morning routine, from getting up, having breakfast, brushing teeth, getting dressed, all the way to, okay, at the end of that, you can have, 5 minutes of screen time before we leave to do whatever is next. Initially, if you don't have pictures, definitely pair your words and your actions with signs, and then see, like, all right, what would be the most important pictures and visual resources to have around the house to make that really clear. The more that we can pair our vocal words with something visual, that gives the child 2 ways to absorb and remember that information. We'll talk more about visual cues shortly. In order also for a child to, for anything that is being maintained by the access function, they have to understand that sometimes the answer is no. So tolerating no and wait is also extremely important. We first want to, as much as possible, establish with the child that their attempts to communicate appropriately really do work. So first, we want to make sure that they can reliably ask for what they really want, even in a rudimentary way, and continue to grant that access before we start teaching no and wait. Let's move on to the next function that I discussed earlier, which is the escape function. And so that's the child engaging in a problem behavior in order to get away from, get rid of, get out of something they don't want to do, don't want to see, don't want to engage on, don't want to have to complete. So there are 2 main ways to increase motivation to engage in activities that you don't want to do. And honestly, that's for children and also for anyone. So when we need to do something and we don't really want to do it, there are 2 main ways that we kind of get ourselves through it. So, and there's not one that's better than the other. In fact, if you do both at the same time, you'll have the best results. The first one I want to talk about is increasing motivation to engage in a task or an activity by just looking at it from the child's perspective and making it better for them or less horrible from them from their own perspective. So that's where we might incorporate some of the things that they like into that activity as much as possible, and also where we want to embed as many choices as possible into that activity. So for instance, a lot of kids really dislike brushing their teeth. But let's say they really like, I don't know why I'm fixated on Baby Shark this morning, but I'm going to go with it. Let's say they really, really, really like watching Baby Shark. So maybe you bring your phone into the bathroom, you click on Baby Shark, pause it, and ask the kid take their toothbrush out of the toothbrush holder. They did that part. We're going to listen to, 3 to 5 more seconds of Baby Shark. Don't worry, I'm not going to sing Baby Shark. Every parent already knows it's burned into their brain, probably to the day they die. So you can just see how you can embed something that the child really likes into an activity that maybe they really, really don't like, that they don't cooperate well with. Even if the child is not at the point where they can grab their own toothbrush and pretty much mom or dad is doing the whole process for them, but we really need them to open their mouth. We really need them to allow the brushing to happen. Maybe they don't like the type of toothpaste. Maybe we could change that a little bit or use a little bit less toothpaste. But basically having 3 to 5 seconds of Baby Shark, and then, all right, 3 to 5 seconds of brushing, 3 to 5 seconds of Baby Shark, 3 to 5 seconds of brushing, and basically going back and forth like that throughout the activity. We might have better results than if we just really push through the toothbrushing activity to the end. So that would be embedding a preferred activity, or even embedding a reinforcer within the activity if that's possible. Also embedding other types of choices throughout the activity. So for dressing, for instance, offering the child, this shirt or that shirt, these socks or those socks. For some kids, that could possibly be motivating. For other kids, they don't really care about what they're wearing. Fortunately, you as their parent, you already know what they care about and what's meaningful for them. So use what they would like to choose as a way to embed more fun, more reinforcement into the non-preferred activity. On the flip side, there are some, not flip side necessarily, but on the other hand, in certain situations, it's very difficult to embed choices or to embed preferred items into an activity, in which case we're going to go back to our handy dandy first then tactics that I already described. That in that sense, we're going to say, all right, I see that you don't want to do this, that you're saying all done to whatever I'm asking you to do. It can't be all done yet. First, we need to finish it, and then it can be all done. And sometimes just terminating the activity, the non-preferred activity, is its own reinforcer, and the child just wants it to be over. But just acknowledging this is still going to happen, that first then can really work for access and for escape. Let's talk about the sensory function. So that's when the child is either seeking out sensory input or trying to avoid sensory input. That's really where you want to go back to looking at if the child needs a sensory diet. What are they trying to accomplish with engaging in that behavior? So for instance, with our adults, I treat quite a few who still engage in thumb sucking or finger sucking. And it's as an infant, we wouldn't call that a behavioral problem, but when it's done across the lifespan, it can really lead to skin breakdown and other health issues. So we want to really look at that. And oftentimes an adult who is sucking their thumb, they're not doing it for attention or to get something from the outside environment. And they're not necessarily doing it to escape anything. They're doing it because maybe for them that's self-soothing, it feels good. It's just a behavior that for them internally has sensory consequences that they enjoy, that they want to continue. But it might not be very good for their skin, for their thumb, for their teeth. And so in that situation, we're going to give them something else, a different item that they can place in their mouth and be able to have that oral motor sensory need filled without damaging their skin. For access and escape functions, we really want to make sure that we're working alongside speech pathologists to make sure that any type of communication that the child needs to learn is really being done in a complete way. And for sensory functions, we really want to work alongside an occupational therapist so that those sensory needs are being met in the appropriate way. Like I said at the beginning, and I know my colleagues have already said, we have to work as a team. No one discipline can possibly have all the answers. And obviously as parents, you would need to seek out a variety of people to really answer every issue that your child might have. Let's talk about some more ways that we can set children up for success in order to obviate their perceived need to engage in problem behavior in the first place. I'd like to talk a little bit more about the visual cues. So we talked about signing. There's so many resources online. Any adult, any parent can teach themselves a few signs and start to learn them and use them, especially if their child does not speak at all yet. They can help prompt, move their fingers, move their hands to help them sign as well. We talked a little bit about a first then board. We can expand on the first then to add some other components to it. So here I have a first then board that also has a timer attached to it. So for instance, you know, the child who hates to leave the playground, we might show them, okay, we're going to be out the playground for 20 minutes and then we're going to go home and have lunch. When we're using the first then board or signing first then, we can also set up even more strategies for success by doing things like, okay, we know from experience and from our ABC data that leaving the playground or leaving a preferred environment out in the community is very, very difficult. So before even leaving and getting in the car to go to that place, maybe let's already set up something fun, something reinforcing that the child can look forward to when they get back. So for instance, if you know we're going to go to the playground and then we're going to come back and have lunch, maybe already help the child set the table and already pick out, you know, their favorite snack or their favorite dessert that's going to go along with lunch, so that when we say like, all right, the timer is showing us it's time to leave the playground. Remember, we're going back for lunch and you had picked to have a brownie for dessert for lunch or something like that. The more that we can give the child things to look forward to, the easier it's going to be to leave the highly preferred thing that they're doing in that moment. The timers can also be used, you know, on our phone. We all carry around our phones. There's so much useful technology. We can look up Google Pictures, all kinds of things that can help. So far as visuals out in the community, just pull it up on your phone and you've got something right there. Another way to show a child what's expected of them using a first then, for instance, I have this one here. It has these flaps at the bottom and underneath it just has a 10 to 1 countdown. So in this situation, we might have set up the board to be like, okay, this is a child who needs to drink more water. They only want to drink juice or they're not drinking enough liquids at all. So you'd be like, okay, first drink. Then maybe they had picked to go, you know, set up their play tent. Be like, okay, we're going to have 5 sips of water. As they take each sip, we put down a number all the way to, you took 5 sips. Oh, put down the last one and it's all done. So pairing our expectations with visual cues can really be powerful and meaningful for the child, and also can just help take away a lot of the emotion of having any difficulty communicating. So obviously communication is a two-way street. So the child might be incredibly frustrated because maybe they really don't understand what's being expected of them. And then of course a parent can be frustrated because the child is not understanding or not following through with instructions and expectations.
Jillian.
Yes.
This is Dorian.
Hi, Dorian.
Mindful of the time. You're doing a fabulous job and you gave us a lot of information, but I just want to let you know to keep us on schedule. It's 11:20. We do have a couple questions. So if you're close to a point of wrapping up and then we can take those questions, that would be really helpful. Sorry to interrupt you. I know that seems rude, but
no. So you were 100% reading my mind, because literally I glanced down at my watch and thought, oh, that gives me pretty much 10 minutes for questions. So I would like to now stop lecturing you and open it up to any questions that you may have.
Fantastic. So we do have 2 questions in here, and it's a really kind of a thoughtful, nice remark from Mary Harris. It's important to remember all families are different.
Mhm.
Some children are not known before birth. Some children come into our lives later through adoptions, fostering, or guardianship. In these situations, what is a way that we can find appropriate reinforcers in a timely fashion?
Really having items around the house in any, whether it's the child's bedroom or a living room, any place that it's safe for the child to crawl around or roam around, and just have toys, activities, maybe the TV is on, and just observe them, see what they go for. If they're not really playing with anything, going over and modeling for the child how to play with something. So I have worked with children who just didn't explore their environments for whatever reason. Maybe it was just part of their disability or part of their history. So, I would just go from item to item without expecting them to engage with anything. I would just sit on the floor and bang on a drum and see, like, are you going to come over and see what that's about? I would do that for maybe 30 seconds, a minute. Nope, you're not interested in that. Okay, I'm going to now move on to this other thing. I'm going to put my hands in the, rice bin and play with it and scoop it and pour it and just kind of model for them. For children who are adopted, who, maybe have a history of trauma, it's going to take longer probably to form to do the pairing, to form the personal connection, and possibly to find reinforcers. It's important to really spend time on that because, like I said, without knowing what that child likes, without knowing their reinforcers, it's going to be really difficult to help them change their behavior. That's a really good point, though. Thank you for bringing that up.
You bet. And let's see. So now we have another anonymous question. What is the fine line? Oh, this one's great. I think a lot of folks want to know about this one. What is the fine line between a child that could have true behavioral issues, as you've been alluding to and discussing, versus a child whose parent does not address bad behavior, what we associate with just typical bad behavior, right? I don't know if there's typical bad behavior, but unruly behavior, right? That kind of thing. So what is that fine line? Like, how do you know, where's the evaluation come in, or how do you find out?
In terms of everyday treating problem behaviors, in a lot of ways, it actually doesn't matter. We do always want to know as clinicians if a child does have a diagnosed disability so that we are approaching them in the most meaningful way possible. So for instance, if a child is brought for evaluation and it's for tantruming, it's, every time we try to go out in the community, they're running away, dropping on the ground, kicking and screaming and whatnot. Regardless of whether that's because those parents have maybe not been the most thoughtful parents, and or it's because the child has autism or some other disability, a lot of the initial steps and a lot of the recommendations for the parents are going to be quite similar. Of course, that can't go on forever. We really do need to know, does that child have autism? Does that child have hearing loss? Is that child experiencing migraines or stomach pains, or are they developing a seizure disorder? So we want to know all of those diagnoses and for them to be accurate. And if it seems tricky to get a second or third opinion. But so far as those real basics of, if a child is whining to get something or to get out of something, modeling and prompting them to sign instead, that would go across the board for anyone, even for a child who is deaf and blind. You would still, if they're, let's say they're in the tub and they start to tantrum because they want to get out of the tub, instead of just scooping them up and picking them up, taking their little hands and signing all done, and then scooping them up and having them get out of the tub. So some of those initial basic things would be the same no matter what the circumstances were.
That's wonderful. I think those are some great tips. Very helpful. Let's see if we, oh wait, I think I see one more question pop in the red. No, that's it. I forgot to pop it over here. You don't see an additional question, do you? No.
So I didn't have a lovely PowerPoint like some of my colleagues, but I do want to say that my contact information will be associated with this webinar, and it's also on our website. So please feel free to reach out to send me an email if you have any additional questions, or you'd like any resources, or you'd like to know like how can you get a first then board, or any of the visuals we talked about, or any other questions or concerns you might have. It'd be my pleasure to help.
Wonderful. Thank you, Jillian.